Welcome everybody, my name is Jason Williams. I'm excited to have you here today for our hospital medicine point-of-care ultrasound course. Today, we'll address volume status. This is really one of the few ultrasound courses tailored specifically to hospital medicine, so I'm excited to share with you some of my insights I've gained over the years. For the full curriculum, go to my website anytime at proceduralist.org. Volume status really is the most useful point-of-care ultrasound exam for hospitalists. When I looked at the first 188 patients I scanned during radar rounds at my hospital, I auto-consulted on our teaching teams to try to find patients where ultrasound could really help the attendings, residents, and medical students with their exams, diagnosis, as well as management plans. And when we were scanning together, 53% of the time, ultrasound provided a new diagnosis. The most common misdiagnoses were pulmonary edema and high or low central venous pressure. And you can see here, covering inferior vena cava and lung and jugular venous pressure were the most common performed exams, frequently resulting in change in diagnosis. So in this volume status course, we're really going to just address central venous pressure as well as right atrial pressure. The volume status exam also includes pulmonary edema, peripheral edema, and effective arterial volume, which we'll address throughout this talk. But I encourage you to go back to my other point-of-care ultrasound courses on pulmonary ultrasound as well as cardiac ultrasound so you can have a more comprehensive volume status exam. But today, let's focus in on central venous pressure. So the best way to assess for central venous pressure is going to be your inferior vena cava. So I'm going to teach you how to get quality images and discuss the pitfalls of those images as well. Then we'll apply that information to some volume status cases, particularly with congestive heart failure and shortness of breath patients. The other way to assess central venous pressure will be the jugular venous ultrasound. And finally, we'll go through other common clinical scenarios like acute kidney injury, leg edema, hyponatremia, and ascites. And finally, we'll talk a little bit about shock. As a hospitalist, I don't deal with shock all that much, but I definitely get some hypotensive patients a couple times a month. And assessing central venous pressure can be helpful in those cases as well. Now, this is a comprehensive course. There's a lot of information in all these 5 parts, so take your time. We've broken it down into segments, and you can always come back and review this material anytime. All right, let's get started with Part 1, Inferior Vena Cava Ultrasound. We'll talk a little bit about the evidence for IVC point-of-care ultrasound. Then we'll really spend most of our time in estimating central venous pressure with the inferior vena cava. We need to set up the ultrasound to find the IVC. Then we need to locate it physically with the ultrasound beam. We need to take some measurements of the inferior vena cava and finally use those measurements to estimate central venous pressure. There's a lot of pitfalls to inferior vena cava assessment, so we want to be aware of those as well. So briefly, if we look at our jugular venous exam, where we try to look for A and V wave pulsations, sometimes we'll shine a light obliquely, we'll try to estimate, does our patient have elevated central venous pressure? We fail 37% of the time. We just can't find the neck veins in patients that are clearly volume overloaded when you do a right heart cath or insert a central venous catheter. So our sensitivity for detecting patients that are intravascularly volume overloaded is very low. IVC ultrasound, on the other hand, the failure rate's only 10%. And as a result, we're much more sensitive in detecting patients with high central venous pressure. They have similar specificities, and IVC ultrasound is not perfect, so we'll talk about some caveats of IVC ultrasound in the future as well. But clearly, IVC ultrasound far outperforms our traditional jugular venous exam. I really think it should be the standard of care when assessing what is the right atrial or central venous pressure of my patient. All right, so how do we find the inferior vena cava? First, we got to get the machine set up correctly. You want to grab your phased array probe. It has a nice small footprint here. Then you want to tell the machine that you're looking for cardiac images. This will help adjust so you have a high refresh rate, and it tells the machine to adjust gain and other software factors to help to optimize your image for you. Then we'll need to increase our gain and depth. Often for obese patients, you need more depth and to increase the gain. So here's what the traditional cardiology orientation looks like. You'll see the liver, hepatic vein, diaphragm, right atrium, and inferior vena cava. Those who have learned from emergency medicine providers may see a different image. First of all, you'll notice the footprint is much larger here compared to the tiny footprint of our phased array probe. This is because emergency medicine is often using a curvilinear probe during their fast exam. They're looking at the belly for trauma and blood, and then they'll use that same probe to quickly look at the inferior vena cava. As a result, they're often on an abdominal imaging mode as well, and their dot will be on the left side of the screen. But traditional cardiology orientation is the dot on the right side of the screen. And so as a result, you can see everything's flipped. Here, the heart is on the left side of the screen instead of the right. As a hospitalist, I recommend the cardiology orientation. That's what the vast majority of internal medicine trained providers are using. Next, I just want to briefly review some of the movements of the probe that we'll be discussing shortly, and will orient you to some of the anatomy that we're looking for. So this is a rocking motion of the probe. Now this is a fanning motion from right to left. And once you align the IVC parallel to your beam, you'll see the IVC elongated across the screen, entering the right atrium, and the liver is your friend. It's going to be the window to see these structures. So let's walk through this a little more slowly. So I want to give you a stepwise approach that's systematic, and I use the same sequence every single time. So first thing, before the probe is even on the patient, is palpate to find the xiphoid process, and then place the probe just below the xiphoid. You want to make sure the probe marker is towards the head. Then we need to slide along the costal margin to find as much liver as possible. Liver's our friend in this case. Then we'll rock the probe to find the right atrium. Then we'll start to look for inferior vena cava. And finally, we'll twist the probe to elongate the IVC. So let's go through each of these. So I recommend palpating down the sternum, finding the xiphoid, and the first soft piece of soft tissue is going to be the epigastric area just below the xiphoid process. This is where you're going to put some gel, place your probe down. Make sure the probe marker is towards the patient's head. This will get your beam parallel in the longitudinal plane. Finally, you want to slide along the costal margin to find as much liver as possible. Usually that's going to be either as close to the xiphoid as possible, or a little bit to the patient's right where the liver lobe is slightly larger. Here you can see why liver is our friend. The ultrasound beams travel through the liver so we can see the inferior vena cava. Bowel gas is the enemy of ultrasound, and so the IVC continues this direction, but we can't see it because the gas is interfering with our ultrasound beam and causing scattering. So we have to find liver before we can find IVC. Once we've found liver, then you want to identify right atrium. One of the tricks is rocking the probe to find the right atrium. Often, the sternum or xiphoid process will obstruct our beam and prevent us from seeing the right atrium, so instead you can slide towards the patient's feet and then rock the probe to angle the beam into the thoracic cavity to pick up that right atrium. Finding the right atrium is key to making sure you identify the IVC and not the aorta. Next, we'll start to look for the inferior vena cava. Often I'll look down and learners will have the probe pointed to the patient's left side. The aorta is on the left side of the spine. We need to get our beam to the patient's right to find the inferior vena cava. So in this case, we would fan the beam towards the patient's right, which will get us lined up with the IVC instead of the aorta. Finally, we often have to twist to elongate the IVC. So if we take a top-down approach, if we're looking through the patient's belly button to their IVC to the floor, if our beam is not parallel, what we'll see on the screen is the right atrium, but the IVC gets cut off. Instead, if we were to twist our beam and get our beam parallel to the inferior vena cava, that will elongate the IVC across the screen. In summary, these systematic, thoughtful movements will help you find the IVC more frequently, and do so in a way that doesn't seem random. Sometimes you can put the probe down, the IVC is right there waiting for you. Other times it's not. And learners often get frustrated and not understanding how to move the probe to find the inferior vena cava. But I promise, if you go step by step through this process, the rate of IVC location that you'll get will be much higher, and your rate of failure will go down. Once we've found the IVC, next we have to measure it. Where to measure? So the location's important, and you want to measure in the same spot every time. So we're going to measure distal to the hepatic vein. You can see the hepatic vein here, and we're measuring just on the other side of it. If you can't see the hepatic vein, you want to measure 2 to 3 centimeters from the diaphragm. Here's diaphragm, we measure 2 to 3 centimeters away. Then we want to measure the maximum and minimum diameters. In this case, the maximum is 3.1 centimeters and the minimum is 2.1. I do recommend freezing this image and taking these measurements so we can try to increase our specificity as much as possible. Once you've found the maximum and minimum diameters, in this case 3.1 and 2.1, then you can use it to calculate the collapsibility. In this case, it collapses by about 1/3 or 34%. In this case, the collapsibility is minimal, it's less than 50%, so I would ask the patient to sniff to see if they can suck more blood out of their IVC into their thoracic cavity, and I'll take the most collapsible index that they can generate. If the collapsibility is less than 50%, ask the patient to sniff and find the most collapsible IVC you can locate. One note here is M mode, and I'm going to encourage you to avoid M mode. The cardiology techs and cardiologists use M mode to calculate IVC, and what that means is they drop a line down the middle of the screen and they measure what happens over this line. It makes calculations very easy for our cardiology colleagues. So in this case, the maximum diameter of this M mode, you can see it here nice and maximized, and then it collapses. So they can just take a quick measurement here, 1.9 centimeters, quick measurement at the most collapsible location, 0.7 centimeters, and they calculate an 83% collapsibility. But you can see they're measuring two different places. The maximum is here, and the minimum is here at the diaphragm. We don't want to calculate collapsibility at the diaphragm. This could be the muscle of the diaphragm just squeezing the IVC and not truly reflective of how much fluid is in the IVC. We want to measure distal to the hepatic vein in both locations, not one location and a second location. So for this, there's some evidence supporting avoiding M mode will give you a little more accurate diagnosis when estimating central venous pressure. Now that we've made these measurements, what do we do with these numbers? Well, in this case, our maximum size is 3.1 centimeters. So that gets us a large IVC, greater than 2.1. And the collapsibility is less than 50%. Here it's 34%. So this patient is estimated to have a central venous pressure of 10 to 20 millimeters of mercury. For cardiology calculations on the echo, they'll often report 15, and that will allow them to calculate things like right ventricular systolic pressure. But for our purposes, this patient has a high central venous pressure. Again, greater than 2.1 centimeters in maximum diameter and less than 50% collapsible is a high central venous pressure. Let's compare to this inferior vena cava. Here you can see it's much smaller, maximum diameter is 1.3 centimeters, and very collapsible, 60% in this case. So this patient's got a small IVC, less than or equal to 2.1 centimeters, more than 50% collapse. So this patient's central venous pressure is somewhere between 0 and 5 millimeters of mercury. Again, they'd use 3 for the estimations of right ventricular systolic pressure. And we would say they have a low to normal central venous pressure. A lot of the live models we scan often have been fasting in the morning, and I see central venous pressures of 0 to 5 all the time in healthy young adults. So it's not necessarily pathologic in these cases, can often be normal. But if your patient has a pre-renal AKI and you see a CVP of 0 to 5, that may suggest to give them fluids because they could be pathologically low. So you always have to put these measurements into the clinical context. And here's the middle category. So here the IVC is 2.1 centimeters, technically gets us in this smaller region, but the collapsibility is very poor at 26%. So it's less than 50% collapse. Again, I would ask the patient, can you sniff and see if they can suck more blood out of the IVC if possible? But instead, we have this kind of mixed category. They end up here in the middle with a CVP of 5 to 10, which is quote unquote normal central venous pressure. So let's look at the evidence briefly for how well IVC correlates with right atrial pressure. It correlates pretty well. And when I say right atrial pressure, it's the same as central venous pressure in these cases for all intents and purposes. So over 21 studies have looked at IVC compared to right atrial pressure, and unfortunately they all use different cutoffs. So I stick to the American Society of Echocardiography guidelines, and those are the numbers I've been sharing with you today. And when you look at the sensitivity and specificity for detecting high central venous pressure, IVC ultrasound is great, 85% sensitive and 85% specific. So I feel very confident if I make this measurement in a patient that I've got an accurate measurement. The one caveat with these studies is the specificity of this middle category is poor. There's a couple reasons. A heart transplant population is often included, and as a result, heart transplant patients may have a small scarred IVC, but could be very volume overloaded and not collapsible. So for that reason, the specificity is not great. So when you have a CVP of 5 to 10, it could be inaccurate. You want to question that result and get a little more specific. So when you look at the data, if you end up in this middle category with a CVP of 5 to 10, if the IVC is more than 35% collapsible, that was very specific for a normal central venous pressure. So if I get in this middle category, I like to ask myself, is it more than 35% collapsible? And if the IVC is, I feel confident this person does not have volume overload. If it's less than 35% collapsible, then you have to use some additional data points, like maybe your jugular vein assessment with your physical exam or with ultrasound in these cases. So let's go back to this patient. They have an IVC that's 2.1 centimeters, which is small, and it's less than 50% collapsible. So my next question is it more than 35% collapsible? And unfortunately, it's not. So I really don't know this patient's central venous pressure. So I'm going to go and do a jugular venous ultrasound assessment to see if I can get a better assessment, because they could be high or normal. It's hard for me to tell in this middle category if the collapsibility is less than 35%. All right, let's cover a few additional inferior vena cava pitfalls. The first and most common one is confusing the aorta for the inferior vena cava. They're right next to each other. So just shifting your probe, fanning from one angle to the next, can really make a huge difference. So here's a few clues to help you identify the aorta in the IVC. So first of all, the location. The IVC should always be on the patient's right, aorta on the patient's left. And we've worked on identifying the right atrium and the hepatic vein because that helps you identify the IVC and distinguish it from the aorta. Remember, the IVC travels through the liver. The aorta is deep to it, and we can see that on ultrasound. The walls of the IVC are different. They're thin and non-parallel, whereas the aorta is often thick, fuzzy, and parallel. And finally, the IVC can collapse. The aorta shouldn't unless your blood pressure is 0. All right, let's take a look at some examples here. So here's an example of fanning from the patient's left to right. These are two different structures. I'll let you think for a sec which one's aorta, which one's IVC. So here we have parallel walls consistent with the aorta, and they're relatively thick and fuzzy. And the liver doesn't come right up to this. So this is an example of the aorta. And as they fan the beam from the left to the right of the patient, you'll see they find the IVC here. And you see some collapse with movement. You see non-parallel walls. You can see here this rise and fall, rise and fall. These are thin-walled, and the liver comes right up to this structure. So this is the inferior vena cava. IVC, aorta. IVC, aorta. How about this one? Remember, the aorta is deep to the liver, and here you see some connective tissue that's echogenic and bright white between the aorta and the liver. So this tissue tells me this is the aorta traveling deep, separated from the liver itself. Compared to this patient's IVC, it comes right up to the liver here, thin walls with collapse. You also see the hepatic vein coming in, and you see it entering the right atrium as well. So this IVC travels through the liver. This aorta is deep to the liver. This bright white echogenic tissue separates the two. So again, here's a quick summary of ways we can distinguish IVC from aorta. The location is important, right versus left. The anatomy, we always want to see the right atrium and hepatic vein whenever we can. Ask yourself, does the IVC travel through the liver, or is the structure deep? Is there some echogenic white tissue between the liver and my structure? IVC walls will be thin and non-parallel and collapsible very frequently. Aorta will be thick, fuzzy, and parallel and should never collapse. Next IVC pitfall we should talk about is the measurement. Often people measure off the midline on accident. We want to be right here with our beam slicing through the middle of the inferior vena cava, maximizing this diameter. If the beam is off to the side at an angle or slit off, we're going to underestimate the IVC size or overestimate collapsibility. This is going to falsely lower the central venous pressure. Here's an example of that. You may think this IVC is very collapsible, but instead they're just fanning the beam from the middle off to the side. There's a couple ways to tell that. This bright white wall of the IVC should be present throughout the entire cycle. So this thin white wall should be present throughout the entire cycle of the IVC collapse. But as it quote unquote collapses, you lose that bright white wall, and instead you're fanning into the liver itself. The bright white wall disappears and you see liver tissue. And so this is an example of fanning off the midline and not true collapsibility. Let's compare here, fanning off the midline, and here staying on the midline. Look, you have thin white IVC walls throughout the entire cycle. And that's what you want to see to make sure you're in the midline, this thin echogenic IVC wall, which disappears when you slide off the midline. Another pitfall to be aware of is circumstances where there's elevated intra-abdominal pressure. If you have a lot of intra-abdominal pressure, it's going to crush the IVC, and that extrinsic compression will falsely lower your central venous pressure. It will make it look small and collapsible. So classically, this happens with tense ascites. The classic scenario is a cirrhotic with tense ascites shows up into the ICU with hypotension. They get 10 liters of fluid because someone's looking at a small collapsible IVC, but it's not due to hypotension. Their hypotension is not due to low central venous pressure. Instead, the IVC is collapsing because they have tense ascites. Abdominal compartment syndrome can cause this, and pregnancy as well. Also think about the thoracic pressures. So if you have high thoracic pressures, it's going to prevent fluid from entering the thoracic cavity, and that's going to artificially distend your IVC and falsely elevate central venous pressure. Several common examples: with severe COPD or asthma, you can hyperinflate the lungs and contribute to distended IVC and neck veins. Tension pneumothorax can do this as well. Tamponade, when the heart is being crushed by fluid, it's going to prevent fluid from entering into the pericardial space. And finally, we really have to talk about ventilated patients. All of the data I've presented to you so far about measurements, you have to throw out the window with ventilated patients. When you are pushing air into the thoracic cavity with a ventilator, it distends the IVC. Instead of when patients take a deep breath in, they suck blood out of the IVC when they're not intubated. So with ventilated patients, we really can't use the traditional cutoffs we've talked about here. One study showed that if you do have a very small IVC, that's very specific for a normal central venous pressure, but otherwise it's hard to extrapolate much of what we talked about for ventilated patients. Thankfully, I'm a hospitalist, and I'm assuming you are as well, so it shouldn't be an issue for most of our patients. All right, congratulations. You've reached the end of part 1 for inferior vena cava point-of-care ultrasound. This is the first step on your way to volume status assessment. So a brief summary of what we covered so far. The inferior vena cava is 5 times more sensitive than our traditional physical exam for detecting high central venous pressure. If you take a stepwise approach, you'll find the IVC very frequently. We want to remember our cutoffs that if the IVC is greater than 2.1 centimeters and less than 50% collapsible, that's a high central venous pressure. Remember, we always have to make sure we're distinguishing aorta from IVC. Always ask yourself a few systematic questions to make sure you're not confusing the two. Keep that beam in the midline of the inferior vena cava during your measurements, and that'll make you much more accurate with assessing central venous pressure. And always keep in mind, does my patient have high intra-abdominal or thoracic pressures? That's going to cause false measurements in either direction. Great work. For part 2 and further curriculum, please go to my website, proceduralist.org, and we'll continue this great hospitalist-based education for ultrasound. Thank you.